Welcome, everyone, and thank you for joining us. My name is Stephanie Wolf, and I am the Membership Relations Coordinator at Population Connection. I'm so grateful to see lots of familiar names and a few new supporters tuning in for this second session of our site visit series, where we will learn more from our Guatemalan-based partners. Today, we will hear from Maya Health Alliance, also known as Wuqu Kawoq. Now, I can't mention our global partners without acknowledging the generous donors whose contributions make these partnerships a reality. PopConnect is a membership-based organization, meaning all of our programs are made possible by the support of dedicated donors. If you haven't donated already, I do hope you'll consider making a gift today if you can. For today's event, I am joined by Population Connection Senior Analyst Hannah Evans. She visited our Guatemalan-based partners this spring and will be sharing photos and stories from her trip. Also joining us is the co-founder and CEO of Maya Health Alliance, Anne Kraemer. Anne trained as a cultural anthropologist at the University of Kansas, where she earned her master's degree and completed doctoral coursework. Anne is passionate about amplifying the voices of women and girls to foster community-driven health programs. Now, if you have any questions for our speakers, please drop those in the Q&A box found at the bottom of your screen. We will do our very best to get those answered along with any pre-submitted questions during the Q&A session. And then for any questions we don't have time to answer live, we will provide written responses along with a recording of this presentation, the presentation slides, and access to the chat box discussion. Now, those are all the housekeeping items from me. I will go ahead and send it over to you, Hannah, to get us started.
Thank you so much. Hi, everyone. It's nice to be here with all of you. My name is Hannah, as Stephanie mentioned, and I'm going to be leading us through the first part of our presentation today. As Stephanie mentioned, I had the great honor and opportunity this spring to go down to Guatemala and meet with all four of our global partners there. And this presentation is going to cover Maya Health Alliance's site visit and the work that they're doing. So I'm going to start off the presentation just by briefly introducing Maya Health Alliance as an organization. I'm going to situate their work then within the broader context of the Indigenous landscape throughout Guatemala. And then I'm going to just talk through using pictures to support me. My site visit with them. We did a one-day site visit together. And then I'm going to kick it over to Anne, who's going to talk in much more depth about the organization, the types of work they're doing, historically, contemporarily, and into the future. And yeah, we'll open it up for questions after that. So as Stephanie mentioned, if you have any questions, please feel free to put them in the chat. We'll get to as many as we have time for today. All right, so Maya Health Alliance is an organization that has been in operation since 2007. We have been working with them for about 2 years, since 2023. And their mission is to build health equity in Guatemala. So they actually work to serve health needs in Guatemala's most underserved communities. They are actually community run and led, which means that 85% of their team members are Indigenous women who live and who live in the communities in which they serve. So the organization really seeks to be a community-led, community-driven operation that's bringing together things like medicine, culture, and language to overcome barriers to better health. Maya Health Alliance is one of the only organizations in Guatemala that actually provides women-centered healthcare services entirely in Mayan languages, and we'll talk through why that's so important. But they work in over 9 different departments throughout Guatemala. So their vision is that everyone, no matter where they were born or what language they speak, has access to quality care. And again, their work provides comprehensive care in communities where patients live and in the Mayan languages that they are most comfortable speaking. So they have a pretty wide array of programming that includes child nutrition, women's health, maternal and infant health, and chronic disease, all of which are integrated in their programs. And I'm sure Anne's going to talk in more depth about that. So last time, I was talking a little bit more about Guatemala's sort of socioeconomic and political situation, and I wanted to focus a little bit more now on Guatemala's indigenous populations because Maya Health Alliance works exclusively with indigenous groups. So, as you might remember from last time, Guatemala has a really high proportion of indigenous populations relative to other places throughout Central and South America. So, depending on how you measure it, anywhere from, let's say, 40 to 45% of Guatemala's 18.2 million people are indigenous. And actually, I was reading yesterday that indigenous rights activists actually argue that the proportion of indigenous populations could be much higher, into the 60% realm. And this is just based on, broader definitions of how you look at ethnicity or self-identification or cultural heritage. But anyway, Guatemala has a really, really high percentage of indigenous populations, and most of them are living in rural areas. So most indigenous groups, over 75%, are living in rural places. There are 24 recognized indigenous groups in Guatemala, the overwhelming majority of which are Maya. So I've included a list of all of the different Maya groups there. There's also one Garifuna group and one Xinca group, which represent smaller proportions of the overall total, but are still very much in existence. And in terms of the indigenous population and the sort of status right now, it's important to know and understand, and I'm sure many of you have a general understanding of this, but indigenous populations all throughout the world and also in Guatemala have, they stretch back, their histories stretch back thousands of years. The Mayan civilization flourished in this region, in particular in Guatemala, for hundreds of years. And this is a civilization that developed super advanced systems of agriculture, astronomy, writing, and architecture. And it's largely considered one of the world's great ancient civilizations. And with the onset of the Spanish invasion in the early 1500s and colonization, that imposed forced labor, conversion to Christianity, and land seizures that continue to sort of pervade in different ways today. So, through these processes, indigenous communities largely lost much of their land and their power and their autonomy, and were subjected again to really oppressive, really exploitative measures that included forced labor and that largely drove indigenous populations off of their land and into marginal lands where they were forced into subsistence farming. All the while, Spanish and Ladino or mestizo populations and elites came into control of the best agricultural areas and lands. Also, large organizations and corporations like the United Fruit Company took control of, again, the most fertile lands as well as the economy. After Guatemala's independence in 1821, indigenous populations continued to be marginalized and exploited. So, for example, they were largely excluded from political participation. They were subject to discriminatory laws and heavily taxed. And in the 20th century, during Guatemala's Civil War, which was waged from 1960 to 1996, the army specifically targeted indigenous communities and systematically engaged in massacres, which were later recognized by the United Nations as acts of genocide because tens of thousands of people, indigenous people, were killed. And so a lot of that legacy pervades today, and it continues to influence the ways in which indigenous populations are able to access resources in their communities and in Guatemala more broadly. So some of the major challenges they face include things like economic inequality, where indigenous families are much more likely to live in poverty compared to their non-indigenous counterparts. So anywhere between 75 and 90% of indigenous communities live in poverty versus 40% of non-indigenous groups. Land access continues to be a challenge as well, where most indigenous populations actually survive on small, overworked plots with poor soil, which makes food insecurity a really big issue. Discrimination also is a major issue where things like structural racism limits access to education and healthcare and political influence. And political exclusion as well is something that continues to act as a challenge as Indigenous groups are not very well represented in government structures, despite representing almost or making up almost half of Guatemala's population. And in terms of things like access to basic resources like healthcare and education, and I'm just going to cover this very generally because I know Anne is going to go into this in more depth, but just language alone is something that largely limits the ways in which Indigenous populations are able to access care and other resources. So again, over 24 different languages are spoken in Guatemala, 22 of them being Mayan languages. But almost all services in mainstream hospitals and healthcare centers are offered exclusively in Spanish, effectively preventing millions of people from accessing care. And this language barrier combined with structural racism and the fact that many Indigenous groups are just not able to communicate, their needs and how they're feeling, prevents them from accessing care and contributes, in a detrimental way to overall health. According to Maya Health Alliance, many Indigenous people would rather die at home than be treated in a hospital where no one speaks their language or respects their dignity. So this hopefully provides some context into why this work that Maya Health Alliance is doing is so important. So in terms of our site visit, I met Andrea, who is the Communications and Development Officer for Maya Health Alliance in Antigua, which is a relatively large tourist destination, a colonial town, a beautiful little city in Guatemala. We met there. She picked me up, and we drove about an hour and a half outside of the city to a place called Tecpan, which is where Maya Health Alliance is headquartered. We picked up one of the community health workers named Glendy and then drove up into the mountains and these windy roads up into these really rural, really beautiful landscapes up in the highlands to a community called Parachine, which is where we went to go to two different households to do checkups on women, two different women who have been working with Maya Health Alliance and who have received healthcare services from them recently. So the first household we went to was the house of a woman named Irma. She's 22 years old and has been working with Maya Health Alliance for the past couple of years. She uses a contraceptive injection, and she got that within the past 3 months. She is she welcomed us with open arms and was, just very grateful for the services provided by this organization. She, like I said, is 22 years old and first got pregnant whenever she was 17. She now has 3 children, and she's the sole provider for her family after her husband unfortunately died. So she is providing for herself and her 3 kids by selling fruit on the side of the road in a very rural landscape. And so she's able to, access healthcare services pretty much entirely because Maya Health Alliance is able to come to her. Again, she lives in a really rural place that has no healthcare facility and no access to family planning. So she just expressed again a lot of gratitude and contentment for being able to access this service. She says, I want to take care of myself because it's difficult with 3 kids already. So these services are really beneficial for me. The second household we went to was that of Christina. She's another Indigenous woman who lives in this community, and she is 27 years old and is receiving the same family planning services, so the injectable contraceptive. She was another one who was super excited to meet with us and loves the work being done by Maya Health Organization, or Maya Health Alliance, excuse me. She's 27 years old and became really interested in family planning after she had a child and then immediately got pregnant. She recognized that that was really difficult and hard on her body and wanted to explore family planning methods. She was told about the organization from one of her community members her neighbors. And at first, she was a little skeptical. She wasn't sure about family planning, but again, she was referred by her friends, and the organization overall made her feel really safe and supported in receiving care. So again, these are community members who are receiving healthcare entirely in a language called Kachikel, which is the Mayan language spoken in this region. So Glendy actually grew up speaking Kachikel with her grandmother, and now is able to offer healthcare services entirely in this language, which is, again, pretty much the only reason that these communities are receiving this type of care. So it's really, really profound work. This is a picture of Glendy, who's a wonderful woman who's doing such important work in many different communities and works super hard and super very passionate about the work she's doing. And she says, everything we do here at Maya Health Alliance is important. We provide family planning services and cancer screenings, and we educate women about their health so that they can make their own decisions about their bodies. And I wanted to also include a quote by Andrea. Again, she's the Communications and Development Officer at Maya Health Alliance, and we spent the day together. She had many interesting things to say, and again, is another one who's super passionate about the work being done by this organization, very rooted and yeah, just dedicated to the cause, which I found to be really beautiful and inspiring. She says, our work is important because we're providing healthcare services to underserved communities. We're supporting over 11,000 patients per year, and we do it in native languages. Our team members, which include backpack nurses, physicians, drivers, and other staff, work together to provide profound changes in the communities we serve. And again, I just, had a really positive, really amazing experience getting to meet with each of these members of Maya Health Alliance and with the community members. And I just feel like the work is very profound, very important, very rooted, and it's a really beautiful example of community-led integrated development. So with that, I will turn it over to Anne, and she's going to talk about the organization in much more depth.
Thank you. Shaker Iwanohe Lautsi Wuch. Good afternoon, everyone. How are you? That's a greeting in Kakchikal Maya, one of the languages that we work in. And I think it's really important that we understand how it feels when you're getting healthcare in another language that you don't understand. So imagine being in a situation that's really stressful and you don't understand anything your doctor or nurse is saying. That happens for millions of patients here in Guatemala every day. And that's where we, Wuqu Kawoq, or Maya Health Alliance, came into creation when we started in 2007. Oops, one second. We started in 2007 really based on the idea that we want to be there for people in their language and in their culture to really provide people with the care that they need. In Guatemala, the challenge that we're facing is that it's one of the most unequal nations in the world. Hannah really touched on some of these key features that are really problematic here in Guatemala. And often, because of this inequality, women and children suffer the brunt of this inequality. Often barriers like language, distance, cost, and mistrust. For the long 36-year civil war that happened here from the government against the indigenous communities, a lot of people don't want to go to the health center. And as Hannah said, oftentimes people will tell us, I'd rather die at home than go to the hospital and be left in the corridor and no one treats me and I don't understand what they're saying to me. I want to be somewhere where I have my family, where I understand what they're saying and I feel safe. And in Guatemala, there are many, many health gaps. Many people don't speak Spanish. They speak the indigenous language. Oftentimes, Mayan women are 3 times as likely than non-indigenous women in Guatemala to die during pregnancy, during labor. And unfortunately, in Guatemala, we have one of the highest rates of malnutrition in this hemisphere, higher than Haiti. Unfortunately, Guatemala has the worst, we're the 4th or 5th worst in the world for malnutrition. Even though here we have beautiful greenery, we have plants and vegetables being grown all over, most of that is for export and not for the families that we're treating and dealing with. And unfortunately, the Ministry of Health suffers from corruption, underfunding, discrimination, and most often they don't go to all of the rural communities. There was a program in 2016 that was completely cut due to funding, and it left over 4 million people, specifically in rural communities, without healthcare. So how did we all start? I came here back in 2003 in order to understand why are there so many nonprofits in Guatemala. I'm an anthropologist, and I really dug in. I lived with communities, learned how to speak Kakchikel. I wanted to understand, what does it mean like to receive services? How can we do better as aid workers, as development workers? But I never thought I would be leading Wuqu Kawoq, My Health Alliance. When community members came to us and said, we need your support. We need help to have care in our languages, in our culture. So we started in 2007, a small team, and now we've blossomed after 18 years into a team of more than 130 people, treating over 10,000 patients a year, treating people all over the country of Guatemala. We're very proud to be 95% Guatemalan, 80% Indigenous, and 85% of our team are women. And that's mostly because the amount of patients that we treat who are women are over 85%. And so we want to reach women where they are by having nurses and doctors who are women and can identify with them, speak their language, and they can really share with and have trust. We also do a large part of our work focused on investigation or research. The majority of our funding comes from the National Institutes of Health in the United States, and we have over 135 peer-reviewed publications. When we understand better what was happening in Guatemala, why patients don't want to go to the healthcare center, why they can't access healthcare, barriers such as cost and language and mistrust, we wanted to build a system that worked and worked over the long period of time. So our solution was building capacity in community health workers. Community health workers like Glendy that Hannah was able to go to the field with. Glendy speaks Kakchikel. She's a nurse. She can understand her patients where they come from. She comes from a very similar community. And that's our goal. That's our solution, is providing care by the people who understand the needs of our patients and meeting our patients where they are. Today, I'm going to talk a lot about women's health, but our programs are broad in spectrum. We work on women's health, family-centered nutrition. One of our partners, Seeds for the Future, is also Population Connections partner, diabetes and hypertension, primary care and community clinics, complex care, which are often patients that we have to remove from the communities. They can't receive care because they need more in-depth care or surgery or cancer care. And we do implementation science research. So where we work, as Hannah shared, we work across 9 departments across the highlands of Guatemala, and we work in 7 languages. Our impact over the last 18 years is that we've served more than 44,000 patients in over 350,000 home visits. So a lot of our patients are chronic care patients. We see them many, many times for diabetes, hypertension, cervical cancer. So we're often seeing our patients many times in a year or sometimes over a decade. We really focus heavily on women's health. We've done over 122,000 women's preventative care visits and 13,600 years of contraceptive coverage. For us, providing women with the opportunity to make decisions about their own body and their future is absolutely essential to the work that we do. And one of our biggest kind of turns in women's health has really been to focus on cervical cancer. Unfortunately, cervical cancer is one of the largest cancer killers of women in Guatemala, which is not the case in the United States, where often women can receive care, receive pap smears and screenings. Here, many women are not able to receive that, or they're scared, or they don't have access, or they don't know about them. And so cervical cancer has really become a big focus for us. We know that in communities where there's high malnutrition, we can reduce malnutrition by 20 to 40% over 3 years in those communities. We've increased hospital-attended births by more than 50% and reduced maternal deaths in the region we're working. And we do more than 60 hours of training per year for every single team member. So I'm going to talk a little bit about our women's health program. Our services really focus on empowerment and education, providing women with sexual reproductive health information and education so they can make decisions for themselves and hopefully for their family. And the services that we provide are preventative care in nature, mostly focused heavily on cervical and breast cancer screenings. We do an array of family planning and maternal and infant health. Our family planning methods, we provide many. We do short-term methods, long-term methods, and permanent methods we do through our partner, Wings, who is also a partner of Population Connection. Our cervical cancer screening, as I was saying, has become a really important part of our work. I'm really excited to share that over the last 2 years, we've been able to transition from doing pap smears to HPV testing. HPV testing is standard, care in the United States and in Europe to really understand if the woman has cervical cancer now or could in the future. With this test, we're able to see if she has the virus present and which genotype of the virus to know that she either has it now or she could get it in the future. So it's been really revolutionizing our work and being able to predict who could have cervical cancer and help them get the care that they need. We also do a lot of follow-up for cervical cancer. So in the field, in the homes, we can do thermocoagulation, which will burn off cancerous lesions. And we also have a team of nurses that will do colposcopies in order to take biopsies and really see further what is happening with her cervical cancer case. Now, if we do get a woman with advanced cervical cancer, we will take her to the Ministry of Health in Guatemala City, which sometimes can be many hours of travel, but we can get her radiation therapy or chemotherapy depending on what her case calls for. And we have a care navigator who takes her by the hand to help her navigate the very difficult systems that is the Ministry of Health here in Guatemala. I want to share a small quick story about something, for me that is so important for a woman to make a decision. This is Doña Rosa. Doña Rosa speaks only Cachical Maya, no Spanish. She's 72 years old and she lives in Sololá. She is an artisan and she works for one of our partners and she weaves bags and blouses and belts. And she came to one of our classes that Glendy taught, and she went through our 6 classes that teach everything from getting your period to going through menstruation to giving birth to sexual reproductive rights to what makes a good partner. All of those things are part of our women's health courses. Well, at the end of the course, she decided, yes, I'm going to have a cervical cancer screening. She'd never had one in her life. So she went and had the screening, and unfortunately, she came back with HPV, the genotype 18, which is very dangerous. And she already had some cervical cancer lesions growing. So her sons and her family didn't understand how she could have this, that she didn't have any symptoms. And Glendy spent a really long amount of time talking with her family, talking with her sons, and talking with Doña Rosa. Rosa was finally made the decision that yes, she would go and travel several hours to Guatemala City to get a cone procedure to get the cancer cut out. I just talked with her last week and she came to visit in our office and she was crying. She was so thankful because she had no idea that she had cancer. And if she wouldn't have gone to these classes, she would have never made that decision. And now she can feel safe with her family, with her business to keep on weaving and keep on helping her grandchildren. And I think it's just one story that education, empowering women with a decision about their own bodies, about real information, makes such a difference. And here in this picture, you can see Glendy holding the speculum. It's a plastic speculum that we use in the field with our backpack nurses. And here Doña Rosa is really looking at it, touching it, feeling it, because she didn't know what a speculum was. And she was like, that's going to go where in my body? Yes, she needs to know what's going to be in her body and where it's going and why, so she can make the decision that's best for her. And I think it's through these stories that we can see the impact of what it means to have amazing community health workers in your community who know your language and understand you. This is one of our quote from one of our obstetrician gynecologists, physicians from the United States, who does a lot of training for our nurses. And I think she really captures it, the importance of the work that our nurses are doing. They're going in the homes, in rural communities where no one else is going, and they're finding cervical cancer, and they're changing women's lives, giving them the opportunity to survive, be present for their kids and for the future. There are challenges in this work. We're working really hard and we're doing fantastic work, but we also have a lot more work to do. Some of our major challenges are including men in family planning. We're a very machista society here in Guatemala, and we have a lot of work to do to overcome that. We're also trying to reach more women who have limited access to information. While cell phones and smartphones are everywhere, we're not reaching everyone, and that includes youth. Getting to Indigenous youth, especially women who usually leave school around second or third grade, it's very hard to find them and reach them and provide them with the information they need. So that's really something that we're focusing on for the future, is to really understand how can we reach young men and women with this information so they can make the best decision for their future. In 2024, just to share some of our data, 98% of our patients were women. We really track follow-up to make sure that our patients know their cervical cancer situation. We had 90% of follow-up within 8 weeks. Our overall follow-up is almost 98%, but we want to make sure people know within 8 weeks. We visited over 8,500 patients and 18,000 home visits. This is just for women's health in 2024. 2,284 women with family planning and 136 cancer or pre-cancer cases were detected and treated. And just to jump in, another really exciting area I think that we've been working on for the past couple of years is maternal and infant health. And our goal here was to really reach patients where they are. Many women don't want to go to the hospital, like we've talked about. But if you can imagine here in Guatemala, the public sector, when you're birthing, you have to go and you enter the hospital and you go alone. You have to give birth alone, not without your husband, without another family member, without a midwife. And if you don't speak the language of your doctor, can you imagine how frightening that would be? So our whole goal was to really meet women where they want to be, which is with their midwives at home. So our whole goal was to really link everything together. Midwives linking to the hospital and making sure women are getting the best care possible. So our goal is to create an early detection process, and that's through the Safe Natal application that the midwives we work with co-designed with us, and accessible care. So having Indigenous care navigators who advocate, translate, coordinate, and provide care for mothers who need to go to the hospital. And in the end, we have reduced maternal deaths. We're very proud to say that we have reduced maternal death in this region, and we're very proud of that. Our goal is to collaborate with midwives. We've been working since 2016 with over 40 midwives who co-designed this checklist-based app. We do everything in Cachiquel. The midwives work together to share ideas and plans. We share everything with the Ministry of Health. The app is all done in audio and Cachiquel and illustrations, and it guides them through prenatal, perinatal, postnatal, and neonatal visits. These are the midwives that we are currently working with. We've just added on 30 more. So we're now working with 70 midwives in the region around Tecpan, which Hannah was able to visit. And then we have our care navigators and some of our neonatal technicians around the edges, and Dr. Esteban, who is our lead physician on this project. Our care navigators, I've talked a little bit about them. We have care navigators who are working with moms and infants, and then we have care navigators who work with cancer and surgery patients. The care navigators both serve to communicate, to support, advocate, and coordinate for our cases. Oftentimes, people are very scared, and it's really wonderful to have someone holding your hand while you're giving birth or while you're exploring a hospital and you don't know where you need to go or what you need to do. And since you're there alone, our care navigators can call your family and let them know what's going on. Care navigators have been absolutely essential in reducing maternal mortality and maternal death in the region that we're working. This graph's a little bit hard to understand, but quickly, the dark blue is the maternal mortality rate in the big region that we're working in around Tecpan, Guatemala, by the Ministry of Health. And the light blue is the maternal mortality rate for the midwives that we're serving. So we're serving over 1,000 births a year. But as you can see, we have suffered several deaths over the years, but we have had several years without any deaths. And in general, what we're doing is trying to reduce maternal deaths in the region, working very closely with the Ministry of Health. And we're really proud of the results. Our impact in this program, since 2016, is we've served over 6,300 births, over 4,000 hospital visits. We've reduced the trend of maternal death, and we're ongoing, always training with midwives. So thank you so much. It's been a pleasure, and I really look forward to speaking with you on questions.
Thank you so much. That was wonderful. I learned a lot in that presentation. I love the work you're doing working with midwives. That's really profound, really important, really coming full circle with every aspect of this situation. Thank you so much for that great presentation. Yeah, we've got a lot of questions here, and I think we've got plenty of time to cover most of them. I wanted to ask you, there's a couple questions kind of asking about the issue around language, and they're questions from different angles, but I wanted to kind of touch on that first. There's a question asking, like, is it possible to mandate translation services at hospitals, maybe even using AI?
Um, it would be lovely if that could happen, but no, unfortunately, the Ministry of Health has not put that into action at all. Oftentimes, nurses who might speak a language like Kakchikel, they might be stationed in a hospital across the country that speaks another language. So unfortunately, they are improving things like that, but there's still a long way to go. And because there's a lot of discrimination, some of the nurses who do speak Kakchikel do not feel empowered in front of doctors or other hospital people to speak their language so that they could help the patient. So there's a long way to go here. And unfortunately, technology and things like that are really lacking in the hospitals.
Hmm. And so, on the other end of that, what about pushing for educating indigenous groups on how to speak Spanish?
I think, a lot of people are speaking Spanish. It's definitely a growing language for many of the indigenous communities. When we still have such a lack of day-to-day services, such as there's no clean water, there's lack of toilet systems, there's so much lack of infrastructure that most indigenous women don't get through second grade. It's really, something that's impossible at this moment. We're looking at getting people enough food and surviving. So really learning another language is not where they're at this moment. And I think a lot of people are very proud of their language and proud of their heritage, and they feel proud of speaking the language that they do speak.
Absolutely. I think it's really important, especially in Guatemala, which has such a rich and diverse population of indigenous people, to work to maintain the culture and identity and language as well. Absolutely. Wondering also, in terms of who you work with, do you work with the Ministry of Health at all? And how do you receive funding? And has that been impacted at all by funding cuts, or what's the situation there?
Yes, we do collaborate with the Ministry of Health very closely in all of our work. We don't receive any funding from the Guatemalan government at all. We can be very agile in the work that we do, and I think that we're able to collaborate closely with them, provide them with data, learning. Like our maternal health program, we've been able to work closely with them and help them identify a lot of information, especially around neonatal death, that they're unaware of. And so it's been a really interesting collaboration to be able to share that data and look more in depth at how we can prevent neonatal death as well as maternal death. And so in order to do that work, we're constantly talking with them and in collaboration with them. And we're currently having conversations around cervical cancer that we hope can lead to better cervical cancer work in the future. We ourselves are not going to work in every community across Guatemala. It's a very large country. But we feel that the research that we do, the data that we have, can help inform the Ministry of Health as well as other nonprofits in the work that they're doing so that they cannot reinvent the wheel, use data-informed information to make the best decisions to help the communities around Guatemala. You asked a question about finances. We receive a lot of our donations from the United States. The majority come from the US. We also have Europe and Canada. We have been impacted somewhat due to changes in this past year. I would say we did not have any USAID funding this year, which we're grateful for, but some of our partners did. So we're looking at if we are going to have to cut back on some of our nurses in women's health because our partner lost some of their funding. We also unfortunately had to end a very large program that was funded by the Department of Labor. And it was focused on looking at the impact of sugarcane workers and their health and chronic kidney disease, heavily looking at heat and dehydration. And we were working carefully with sugarcane companies here in Guatemala. We were working with our partner, the La Isla Network, and it was an $8 million grant that was cut to our partner, and we lost the next 2 years looking at this really important piece of kidney disease and what happens when you're working under the heat. In general, we're very grateful to not have lost major funding, but we're also hesitant at what the future may hold over the next 6 months as some of our NIH grants are being renewed. It's always in transition right now with the NIH, and so we're hopeful that our current 6 large projects will be renewed moving towards the future. But we're going to see what happens.
Thank you. So funny. I did my master's thesis on chronic kidney disease working with La Isla Network.
Oh, wow.
Yeah, interesting. We'll talk about it later. Yeah, so thanks for that. Unfortunately, there's so much going on in the wake of funding cuts and so much precarity, but I'm glad that you're able to maintain a lot of the important work and even expand it despite the limitations. Um, in terms of how community members access care, are there like qualifications or requirements that a family or a woman must meet in order to be able to receive services? Do they have to pay for these services, or how do you go about finding community members to work with?
Yeah, so our patients, all of our services are completely 100% free for all of our patients. And we go to communities. So we sort of do our clinics in different ways. We do have general clinics that the Ministry of Health has asked us to hold in their health centers. So sometimes we do it there because they don't have the available family planning methods or cervical cancer screening methods. And then a lot of times we do backpack nurses. So literally nurses, they have backpacks with all the family planning methods, everything to do cervical cancer screening and breast cancer screening, and they go to the communities. And oftentimes we work with the COCODEs or the community development groups to schedule our visits, women's groups who want us to invite us to come. And sometimes we get a lot of referrals from mouth to mouth. So people who are just referring because they've had good services with us. So we sort of cover regions across Guatemala based upon our partner organizations, because we don't want to duplicate care. We work closely with wings. And so our goal is to not hit the same communities, but be able to be on the same page. We're going here, you're going there. And our goal is very, very, very rural. So we're really going into communities where no one else is located.
Mm-hmm. And I just wanted to ask you before we move on. So you said obviously you're working really closely with the Ministry of Health, but would you say that the government overall is generally supportive of the work you're doing, and or do you ever face backlash or anything like that?
Yeah, great question. I think right now, the current president, Bernardo Arevalo, and his team is very open to the work that we're doing, very open, I would say, to nonprofits and to progress across the country of Guatemala. But it's difficult to make changes in a country that has had so much conflict and so much discrimination for so long. So I think there are some really great people making some really great inroads, but it can be very slow and very difficult. The current Minister of Health, Joaquin Barnoya, is fantastic. I think he's really pushing a lot of great things forward, but it's a big engine to turn and make a lot of change. So I think it's exciting to see what's happening right now. It feels some good energy, but also people are frustrated. I think the general public feels a little bit of feels frustrated because things like infrastructure and roads and ports have major problems. And so that's really what impacts people on their day-to-day life, and people feel very frustrated by that. So there's a lot of conflict around what the current president is doing. So I think right now we're really able to make some really big steps forward, especially in women's health.
Mm-hmm. Definitely. Thank you. And in terms of the work you're doing being like grassroots and community led, can you just speak to the importance of that in terms of the work you're doing and how that can potentially influence broader health policies? Like, why is it so necessary to be grassroots and community led?
Great question. I think it's very important that we understand that not every community needs the same thing or has the same barriers. And I think what we've done really well is to listen and to understand what communities need, and that we can amplify their voices and say, we hear, we understand, and this is the work that we're going to do. And this is how we can do long-term change. When I first came here 20 some years ago to really understand the impact of nonprofits, there was really a lack of nonprofits that understand the communities and wanted to empower the communities to make their own change. And I think that has changed a lot. There's a lot more nonprofits now that can connect with the communities, that can understand with the communities. But I think the importance of what we're doing locally can transcend across the world globally. Looking at our maternal health program, we've created this picture-based app that works with midwives. And this technology can go to Africa, can go to South America, can go to other places, and it can be adapted locally very easily to save mothers' lives. And I think that's something that we like to really see here is how can the impact we're having locally, be spread across the world, even though here it is very important to understand language and culture, but how can you take these key learnings and share them around the world?
Thank you. Thanks also for including in your presentation the various challenges that you as an organization are facing. I think that they're really good to just kind of outline as a way to kind of collaborate and find collective solutions forward. And I just wanted to ask you, I mean, you were talking about men and family planning and that being a challenge to include them. And I was wondering, in terms of Indigenous populations, and maybe that varies even within the group of Indigenous populations, but especially also compared to Ladino populations, how do men in family planning how does that work? Is that something that's more accepted or less accepted? Is it more difficult to kind of include men? Or yeah, what's the situation there?
Great question, because men really can influence the home here. It's a very machista culture, meaning often that men feel they're owners of their wives, owners of women. They make decisions for them. And in many of the communities where we're working, women have to ask permission to get a cervical cancer screening. They have to ask permission in order to get family planning. Of course, some women choose to get it without asking their husbands. I'll share a quick story about a mother who had several children and wanted to not have any more. And she told, Glendy was her nurse again, and she told Glendy, like, I really want to get an implant in my arm so that I don't have to have babies. I already have 5 and I don't want to have any more. And so Glendy and our nutrition technician went and she said, please make sure my husband's not coming and keep an eye out. And so Glendy put in the implant. They did it really fast and everything was fine and they left. Well, the woman who received the implant later called our nurse and said, I need you to come take it out because my 9-year-old son overheard me speaking with you and he knows I have the family planning method and he threatened to tell my husband. And so you need to take it out. And so we did everything we could to convince her not to, but long story short, machismo is something that's very alive and well here, and we have a long way to go. And that's why it's so important that we can talk more to youth about sexual reproductive rights and health, and so they can get more informed and make your own decisions. On the other hand, over the past couple of years, we have more and more partners, men and women, coming together to our clinics to make choices about family planning methods, but we still have cases like I just explained. So I think it's really, we have a lot of work to do. In general, Guatemala has had a very high population growth rate for a very long time. It has reduced. Guatemala, I think, is now around 3.4%, like 3.4 growth. But when you go to the indigenous rural communities, it's still much higher. You see women with 5 and 6 and 7 children. When I was first here, it was often 12, 13, 14 children. So I do think it is reducing, but we still have a lot of work to do.
Absolutely. Thank you. And thanks for sharing that story. Lenny was able to tell me that one too. It just really speaks to like the lived experience of people trying to access basic care and resources and how dangerous and violent it can potentially be for women.
Yes.
There was a question asking about population growth rates and how this work informs the mission overall to slow population growth and to allow women to choose to have smaller families. And so I just wanted to ask you, in your experience working with women, now that they have access to the resources that allow them to control their fertility, do they often want to have fewer children then?
Yeah.
Yeah.
Yes, I would say most women do. And a lot of it comes around malnutrition. A lot of women, malnutrition is more people understand what malnutrition is now and how it's affecting their children. And a lot of women understand that by spacing their births, they're able to provide more food to their children. And sometimes we talk about women with, okay, if you only have one tortilla, and you have to feed 10 people versus 3 people, what does that look like for your family? And a lot of women say, I really want to wait. I don't want to have so many children because it's a lot, it's expensive. You need a lot of food. And so I think more women are feeling empowered to make that decision, especially those who are able to go through classes and really understand how it affects your body, the changes, the secondary effects, and things like that.
Absolutely. In terms of what you're looking forward to in the future, are there specific innovations or initiatives that you're excited about, that you're interested in pursuing, that you have goals to achieve in the immediate or long-term future?
Definitely. I think we're very excited about cervical cancer work and the impact that we're having. We are currently working on using a different technology that will greatly, vastly reduce our price on doing HPV screening from around $45 to $8. And so
Wow.
for us, that's fantastic because we're going to be able to reach more women and really provide a service that is state of the art, absolutely incredible, that all women deserve to receive. And I think the other piece is around our maternal infant health. We're working on more innovations on the application that we have using machine learning and AI to help midwives make decisions based upon the heart rate of the child, the blood pressure of the mother, all so that the midwife has power in her hands to make the decision whether the woman can birth at home or go to the hospital. And the whole goal is to save women's lives, but that it's done within their culture, within their language, and a way that they're part of that decision making. So I think we're really excited about those two pieces that are happening right now in our work. We're also really looking towards building an institute of learning and teaching. Our long-term goal is to really be able to help teach the Ministry of Health, help teach others here in Guatemala about the work that we're doing, the research that we have, the impact that we're able to do here so that we can help train others so that they can do that across the country and hopefully across the region and the world.
Beautiful. Yeah, there's a question actually asking that very thing, looking at and wondering if Maya Health Alliance's work could be applied in terms of healthcare initiatives or the work being done to other parts of the world. And I think you just answered that. Yes,
Mhm.
right. Ostensibly, as absolutely. Um, we're about to wrap up here. We've got about 5 minutes left. I wanted to ask you, well, there's a question that's not going to take long to ask, that I'll ask you first, which is asking about funding. Do you get any funding from the Gates Foundation?
No, we do not. Currently, Gates heavily focuses on Africa. We have talked with them and we're hoping that they're going to look more toward Latin America, but we don't currently have any funding from Gates.
Mhm. And you partner with other similar like-minded organizations that we also partner with in the area too. So you have
Yeah.
Wings, and do you partner with Manos Abiertas?
We do, Manos Abiertas and Seeds for the Future and Wings. They're some of our great partners in malnutrition and women's health. So definitely, and many other nonprofits in the region. We find it absolutely essential for partnership because we can't do this alone. There's absolutely so much work to do.
Yeah. And why do you think that there are so many nonprofits throughout Guatemala?
I think
It,
there's a couple of reasons for that. I think one, it's in a beautiful country. Guatemalans are extremely kind-hearted, wonderful people. So it's really easy to fall in love with the country and with the people. And there's a lot of need. So I think people come and they see how much need there is and they want to help. But I also think it's important that people always keep in mind we don't want to harm when we're trying to help. And so I think that's why, research, data collection, really working at the local, level, working in the language of the people is absolutely essential.
Mhm. Do you partner with Friendship Bridge?
Yes, thank you. They're one of our main partners, and I forgot to mention them. Yes, we work very closely with Friendship Bridge, providing preventative care services for women for many of their clients across the Highlands.
Wonderful. What a great community you all have together. I want to ask you, what gives you hope? I know right now we're facing so many challenges, so many imminent threats at pretty much all levels and scales, and it can be hard sometimes, especially working in doing the work you do to maintain a positive attitude. And I wanted to just ask you, how do you do that? Yeah.
Great question. I think for me now, being farther away from the day to day, it's often our nurses and our team members who some of them have started with us over a decade ago, and they started with us as a entry level nurse, and now they've graduated from college, or they're doing their master's degree in nursing, and they're managers who are running data sets of thousands of data, and they're making decisions, and they're empowering their other nurses and their team members, and they're going to conferences in other countries. And that for me is incredible, because that for me is sustainable. It's not me doing this work. It's a Kakchikal speaking nurse who's running data in her community about women in her community, and she can make decisions about what's the best for the community. And I think for me, that's sustainable, and that's the kind of work that we want to be a part of. And that gives me hope to see hundreds of our team members who are growing and learning every single day. And that if we're not here tomorrow, we're leaving hundreds of team members behind who can make change in their community.
Mhm. Thank you so much. Yeah, it was really inspiring just to get to meet with, the members of My Health Alliance, and to just see and experience how passionate and driven they are, and how much they believe in the work being done. So it's a real testament to, yeah, just how profound this work is. Um, Thank you so much. We've actually got 1 minute left, and we've answered a lot of the questions. So I think we're going to go ahead and end it here. Thank you so much, Anne, for your wonderful presentation and for such an engaging Q&A. For those questions that we did miss, we will follow up in an email after this with information about the talk, as well as answers to the questions that have been unanswered. So stay tuned for that. And thank you very much. Have a great day.